Sure. Thanks, Rachel. Thanks for having me, and thanks for everyone for attending today. My name is Joe Lillington. I work at the Health Economics Unit, which, if you don't know, is NHS consultancy. Um, so we operate for the Midlands and Lancashire Commissioning Support Unit, but we more generally do work for lots of different kinds of organisations, whether that be sort of centralised organisations or ICBs or charities or trusts or all kinds of sort of organizations. But today I'm going to be talking about a project that we've been doing on epilepsy, and in particular, epilepsy in children and young people, to look at the impact of specialist workforce. So I'm just going to share onto my slides and go from there. Do feel free to ask me any kind of questions as we go through. Me, perfectly fine with that. But I hope you find it interesting. I hope you can learn something about epilepsy. And this was quite a sort of good project in the sense that we used lots of different kinds of techniques to try and build a sort of robust evidence base for this question. So I'm going to talk firstly just around what is epilepsy, and then later on we'll get into the sort of meat of what the project was. So epilepsy, if you're not aware, it's a neurological condition which causes seizures. And the word epilepsy literally comes from a Greek word called epibilium, which means surprise. And so the reason it's called epilepsy really refers to this sort of sudden nature of seizures that people with epilepsy can get. Now, epilepsy, fundamentally, it's bursts of electrical activity with a wide range of symptoms. So when you have a seizure, for instance, with epilepsy, there can be the sort of classic muscle contraction and jerking, which you might associate with that, but there can also be other symptoms. So people having seizures can result in sort of weakness. They can have staring, they can have anxiety, they can lose consciousness. Now, seizures themselves don't necessarily indicate epilepsy, so you can have non-epileptic seizures, but epilepsy itself is a chronic condition. It's a lifelong condition, and yeah, definitely worthy of our attention. Key facts: the most common brain disorder in children, about 102 out of every 100,000 cases occur annually in the first year of life, and in about 1,000 of every 1,000 individuals, about 7.6 will experience epilepsy over their lifetime. Now, in quite a high fraction of people with epilepsy, the seizures can be controlled, and they're controlled through medication. But so it's about 70% of people, but about 30% of these can't be controlled. This is what's called drug-resistant epilepsy. And so people with uncontrollable epilepsy will have seizures, very often. Epilepsy can also be linked to other conditions. So there's a lot of comorbidities associated with epilepsy. For instance, there's a link between epilepsy and mental health. So there's a big driver in integrated systems right now to increase the prevalence of screening of mental health for those with epilepsy. But also there's links to sleep disorders, to ADHD, to autism, and to other learning difficulties. So there is interest in the Midlands to do research linking epilepsy and, for instance, learning developmental conditions. So what causes it? The cause, to some extent, is quite unknown. There's definitely a genetic factor. So 1 in 3 people with epilepsy have a family member with it. But there's also an environmental factor. So if you have strokes, if you have brain tumors, these other conditions mentioned here, for instance, drug or alcohol misuse, then that increases your risk of having epilepsy. But I would say, yes, we know that these factors influence getting epilepsy, but there's still a lot to be done around what causes it. There are many types of seizures. So sometimes seizures can occur in very sort of localized parts of the brain. These are called focal seizures. Sometimes they're more generalized. And sometimes it's the sort of onset, the origin of where these seizures occur in the brain can be unknown. But there are lots of kind of different types of seizures. So sometimes you can have a seizure which is all about sort of jerking and contraction, the sort of classic seizures, but sometimes you can have seizures where, your eyes might flip from left to right, or you might have a head drop, or you might sort of, have almost laugh. That's the kind of one of the classic types of seizures. So yeah, just to kind of, I thought I'd put this in first aid. Then if you ever experience anyone with having a seizure, this is what you do. So you really want to record the timings of the seizures, keep them away from hazards, make sure that their movements are not restricted, call an ambulance if it seems like an abnormal kind of seizure. So, I mentioned that some children and young people will have seizures every day. So there is a certain level of understanding the baseline of the seizures. And if it seems like an abnormal one, or if maybe if it's occurring for a long time, an abnormally long time, then you would call an ambulance. But I think sort of the key thing about epilepsy is very complex and requires high quality care planning for children and young people. And this information really has to be given to both the child and also their parents and their carers and their schools, which is where I think, the subject of this presentation, which is all to do with the specialist workforce, comes in, because it's the specialist workforce that can provide this high quality and very individualized care planning. There are different kinds of seizure triggers for people with epilepsy. So sometimes sleep deprivation, the time of the day and the night. So some children can have seizures when they wake up. Some will have it when they are a bit poorly due to fever and illness, or when they're teething, for instance. So that the frequency of their seizures or the severity of them can go up. But there are other triggers as well. But sometimes it can just be quite random. People can have seizures, due to no kind of obvious trigger, but it can be sort of just because. To diagnose epilepsy, you can use various different imaging modalities. Commonly use EEGs. So you put some electrode sensors on the brain and you measure the electrical signals. But they can also, look at MRI scans. There are certain markers on an MR scan that can indicate epilepsy, but other imaging as well, shown here. And in terms of treatments, there are lots of different types of treatments. The predominant one really is around medication, so anti-epileptic drugs. But there are, you can have surgery to remove small parts of the brain. You can have what's called VNS implantation, where you put a small device into the vagus nerve within the brain, deep brain stimulation. And the final one here is called the ketogenic diet. So the keto diet is it's a very high fat diet, which the idea really is to get a child to have ketosis. So this is having the right level of ketones in the brain. And the idea behind this is that if you get the right level of ketones, it can sort of stabilize the frequency of seizures. It's still the jury is really out on how it works and if it will work on a child, but it seems to have a positive effect in some cases. So lots of different anti-epilepsy drugs, commonly used: sodium valproate, lamotrigine. Good and bad effects, of course, with drugs, but it's important the medication usage is appropriate. So children, there's the right choice of having which drug to take, if at all, and the right dose. And in some cases, drugs won't work. You have drug-resistant epilepsy, and it's important that specialist workforce don't overly prescribe drugs which will not work, because they will have some side effects. So this is just a chart, for instance, from a well-known organization called Epilepsy 12, which shows you the percentage of children who are on different kinds of drugs. So you can see here that there is a cocktail of drugs being used out there. But within epilepsy itself, there are lots of savings that can be made, I think, to healthcare. NICE has estimated the combined direct and indirect cost of epilepsy in England to be about 2 billion a year. In the UK, the cost of misdiagnosis is about 270 million, so it's not insignificant. And also, there are numbers on the ranges of thousands of people living with unnecessary seizures, and taking drugs they do not need. So it's quite an interesting chart here. This tells you across different providers on the x-axis, how much are they spending on one particular drug per £1,000 that they spend on the control of epilepsy. And you can see here that if you look on towards the right, the sort of numbers are around nearly £200 for every £1,000 spent. And if you look toward the left, it's about £50. So big variation in the money that they're spending on drugs. And I suspect that this doesn't correlate with different clinical needs across providers. This is something else. So, and this is just a map, again, showing the same thing, but just on geography. You have some areas which are in red, i.e. they spend a lot on drugs, some which are paler, so they spend less. Now, so I said lots of potential for cost savings in epilepsy. I put here just a few examples of some of the areas in which specialists might suggest that there might be improvement. So some people say that they should increase the use of surgery instead of pushing sort of anti-epileptic drugs. Some people say increase the sort of workforce, the specialist workforce, and here we're talking about epilepsy specialist nurses, consultants, and pediatric neurologists. But there are, other kind of areas in which people say there can be cost savings. But for really this project, just looking at the times, checking, yeah. So in terms of this project, we're looking at the impact of the specialist workforce, and in particular, 3 different types. So ESNs, which stands for epilepsy specialist nurses, consultants, and then pediatric neurologists. And we're looking across England and Wales, and we're looking at children and young people. And by this, we mean really ages less than 24 years old. Now, this is quite an open question, really, understanding impact. So impact can mean lots of different things, but we're trying to tackle it from quite a few different angles, and we're looking at both non-economic and economic focus, because yes, it's important that children have improved outcomes, but it's also important for the healthcare system to make cost savings, and because ultimately costs are very important in driving change to the healthcare system. So this was really a mixed methods type approach. We had stakeholder workshops, we had a literature review, we analysed lots of healthcare data, and in particular I used something called epilepsy 12 audit data. But we also did some economic analysis, and I'll just briefly sort of talk around some of these points and then give you the key findings. The stakeholder workshops were very interesting. We had lots of experts across different kind of areas of epilepsy and also different trusts. So BARTs were present, UCLH. We had the charity Young Epilepsy, a few other kind of major trusts, who provide very good epilepsy care. So yeah, it wasn't me at all just doing this work. There were lots of people, and I put a big list here. Lots of people from the health economics unit were involved in this work, who are either specialists in data analysis and modeling, or economic specialists, or evaluation specialists, or client engagement. And then on the right here, we have a long list of stakeholders who are involved as well, ranging from across NHS England to specific trusts. And they all have different kind of hats. Some are epilepsy specialist nurses, some are consultants, some are pediatric neurologists. Okay, so from the workshops, we asked the question really, how does specialist workforce likely impact outcomes in children and young people? And you can separate these out into different types. Sometimes, these outcomes might relate to the healthcare service. So some people say that if you increase the specialist workforce, you can have a reduction in UEC use, so reduction in ambulance conveyances, reduction in emergency tendencies, ICU admissions. Some people say that there's benefits to clinical outcomes, so children can have less frequent and less severe seizures, and also have better diagnosis of anxiety and depression, for which we know that there is a link between epilepsy and mental health, and quite naturally there will be. Patient outcomes, so there was a lot of discussion around wider patient outcomes, not just health related, but more kind of socioeconomic ones. So the fact that if a child has access to specialist workforce and they can control their epilepsy better, they will have fewer missed school days. They will be allowed to go on school trips, all the kind of benefits around quality of life, which is important for epilepsy, because in many cases you're not going to cure it, but you can make the best of it. And the fourth kind of set of outcomes really was around economic outcomes, this idea around reduced costs linked to prescribing and diagnosis, and generally more of an efficient use of resources. So we had the workshops, and we also did a logic modeling workshop. And if you haven't heard about logic modeling before, all you're trying to do is link together what are called inputs to the impact. So an input might be, in this case, what activities can a specialist workforce do? So that might be that they need to have training, they need to have aligned priorities from a policy perspective. And then you kind of funnel these through to what activities would they actually do to the child. So they might have clinics, or they might offer a kind of service where a child can get in touch with them directly. And there are naturally outputs and outcomes associated with this. So an example here is that if a specialist workforce could do more mental health screening, then there'll be better diagnosis of mental health conditions. So we were really just trying to sort of draw together some ideas here around the likely impact. We also did, as a kind of second methods, a literature review. So we looked, particularly Luca Pacifici, who's a senior economist in the HEU, did a lot of research into the existing evidence base out there to look for what studies have been done on the specialist workforce and how they might influence outcomes. So I'm not going to go into them in any detail, but just by way of an example here, the blue text, there was a paper done which showed that if a child has reduced access to an ESN, an epilepsy specialist nurse, that's associated with an increase in pediatric epilepsy admissions. So we did a review, but also there was a nice analysis done a couple of years ago, which showed that ESN-led interventions can generate considerable cost savings, which again is sort of very supportive, of there being an increase in specialist workforce. The findings, remain the same when extrapolated to the population of children and young people, and they suggest that ESN, epilepsy specialist-led interventions, are more likely to be cost-effective when provided to those with severe epilepsy. So we did up till now, we've really just done qualitative stuff, but now we're kind of moving on to analytics. And to do this, we were using, to assess the impact, we were using epilepsy 12 data. And if you've never heard of epilepsy 12, it's audit data. And there are two types. So one is organizational level data, which can tell you how are pediatric epilepsy services organized. So it will tell you the numbers of staff at different trusts. It will tell you whether or not they can provide epilepsy specialist clinics. But also there's a secondary side to epilepsy 12, which will tell you about clinical data. So this is individual person data, where a child's care, and this care can cover lots of different aspects. It could cover diagnostics that they've had, it could cover drugs that they've had, it could cover care planning information that they've received. So when we're doing this kind of project, we're really, because epilepsy is very complex, we're really trying to tackle the analytics from, let's say, a simple to more advanced level. So we would always start off just by simply exploring the data and just looking at, maybe the correlation between one or two variables. Very kind of simple stuff, but important for you to get a good grasp of what the likely impact might be. But we've also kind of moved on to other kind of techniques. So we've done staff spend analysis, where you look at how a trust's spending their money on specialist workforce, and is there a link there to outcomes. But then we've kind of gone further, and we've gone into more advanced analyses, something called factor analysis, something called causation. And I'll just, because I know this is an analytics group, I'll kind of touch upon them a bit later, just to explain why they are useful, and how they, why would we choose them? So epilepsy 12 data, as I said, contains lots of information. It will tell you about provider information. For instance, what level of whole-time equivalent staffing does each provider have? What functions can epilepsy specialist nurses do at those different providers? Because there's quite a broad remit of functions that they could provide. But it will tell you also, has a child had access to a nurse? Have they had an individualized healthcare plan, which is an important document for epilepsy? Have they had an annual review? Have they been given rescue medication? Just a couple of graphs. So the graph on the left tells you all about a child's access to the specialist workforce. So it will tell you the percentage of children and young people. For instance, if we look at the third bar, input requested and achieved from a ESN, it tells you about 80% of children have had access to a specialist nurse. So it's definitely not 100%. There is room for improvement. Equally, we can look at what functions can a provider provide for its nursing. So this is the graph on the right, which tells you percentage of providers who can offer different ESN functions. Now, for many of these functions, it's the sort of percentages is okay, but if we go towards the bottom, things like the percentage of providers who are able to support specialist nurse prescribing is only about 40%. So there's room for improvement there, room for change. I mentioned that we've done some factor analysis. So I thought I'd just briefly talk about this because it's an analytics group. Factor analysis is really what's called an unsupervised machine learning technique, meaning that we're trying to sort of understand the structure of our data, but it's not labeled in any way. So and we're using this because we want to break down this complexity in our data, which can have hundreds of variables, which we want to simplify down to understand what are the really important ones. So we're using factor analysis here because with our sort of entire data set, factor analysis can describe how this data can be explained by just a few independent factor groups. And within each factor group, there is a link between the variables in your system. So this is very good, and I'll kind of give you an example why. So we did factor analysis on the data, and one of the big factor groups that I found was that a child who has access to a nurse is much more likely to have received specific care planning information. This information might be on how to contact the service. It might be what to do in relation to first aid. If they fall down and they hurt themselves, what do they do? It might be around general participation and risk. If they want to do sort of school activities, is there information there on what happens if they have a seizure on a school trip? But there's lots of other types of information that can be useful for both the child and for the parents, for the school, etc. So we did factor analysis, we did some other analytics. We also did something called causation. Causation is really the sort of gold standard that you want to find in analytics, because it can tell you, it can really tell you, does the specialist workforce really impact these particular variables? So it's not saying that it's going further that there is both an association, but there's a real direction there. So we used a particular technique, and you can look it up, called the Peter-Clark algorithm. I'm not going to go into any detail, but it's a very strong statistical technique. And all we're trying to do is just to get more evidence that the specialist workforce can impact children and young people's outcomes. So just by way of example, this graph here shows in the center this key variable in that a child has access to a nurse, and all of the variables around it are sort of outcomes associated with that. So we could see, for instance, that a child who has access to a nurse causes there to be an increase in details of how to contact the pediatric service. So there is benefit there. So the fourth method, I'm just looking at the time, just check. Yeah, we're okay. Talk for another 5 minutes, 10 minutes, and then I'll take some questions. But the fourth method we've done is sort of economic analysis. And what we've done is we've created a tool to help trusts and health boards measure the impact of changing their specialist workforce. And this is, for any kind of economists in the room, this is what's called cost-consequence analysis modeling. And with cost-consequence analysis, we are comparing costs to benefits across, let's say, 2 different scenarios. So one of these might be, in the case of the specialist workforce, the sort of baseline current levels that a trust has. And the alternative scenario might be having an increase in nursing. So we can look at what are the costs associated with those different levels of staffing, and we can look at the relative benefits. And really, we're using a range of outcomes here. So some outcomes we know are important for clinical, from a clinical perspective. So that might be numbers of children with an anxiety diagnosis, numbers who have achieved seizure freedom. Some are more kind of on the resource side of the system. So the length of stay in hospital, the numbers of attendances to a GP. But you can also, the good thing about cost-consequence modeling is that you can have much wider benefits. So I mentioned earlier about education. You could have an outcome here which describes numbers of missed days of school. So this is the tool. We're gonna try and push it out to as many trusts as possible so that they can have a tool to provide evidence-based decision-making around changing their specialist workforce. In the last 5 minutes, I'm just going to briefly talk about what the key findings are with this project. A really important one is that specialist workforce, in particular epilepsy specialist nurses and consultants, are likely beneficial to epilepsy care activity. And that's based across all of the types of analysis and the workshops and the lit review that we did. So it's looking at kind of really having tackled this problem, but from a variety of different angles. So I mentioned that a child who has access to a nurse is significantly more likely to receive various types of care planning. A child who has access to a consultant who specializes in epilepsy are significantly more likely to have an annual review. So that's the kind of an example recommendation around the specialist workforce. There is significant variation across providers, across trusts in their levels of staffing. Some providers have very low numbers. So on average, the low numbers of workforce is clear. And also some providers, the functions that epilepsy specialist nurses can do could be also improved as well. We have some recommendations for the data side of things. So Epilepsy 12 is a very strong data set. It's very high quality, but it does tend to focus on what's called activity and not outcomes. So, that's always the classic case with most data sets out there, is that they're very much based on performance. But really, to drive improvements for children and young people, you really want to go towards outcomes, clinical and resource outcomes. The literature review that we did identified that there is potential for healthcare cost savings and efficiency gains from the specialist workforce. It equally showed that there is a need for more standardized and long-term research. And finally, well, actually, penultimate slide. So providers really need, well, they can use our tool to supply their local data within our cost consequence analysis framework to understand the effect of changing their specialist workforce. So one final key finding, and then I'll kind of wrap up. One of the clear things about this project was that when we were looking at the specialist workforce, there's no natural comparator. So ordinarily, there would be in a sort of, ideally, you'd have a randomized control trial which looks at the effect of no specialist workforce versus specialist workforce. There wasn't this in this case. So we tried to use various alternative measures to do this. One of them was that we looked at children who have access versus no access to specialist workforce. Another was that we looked at different kinds of providers, some who who have low levels of expenditure on the workforce and some who have high. But really, you want to have a natural comparator, and that's really to be driven by NICE guidelines. So there's another recommendation. So I hope you found that interesting. I mean, overall, it's a very interesting project. We have sort of three main hopes, I think. One is that for the specialist workforce, it encourages ICBs to look at their workforce levels and the benefits of increasing this. And our tool can be used to support this as well as this project's findings. From a data point of view, we have several recommendations that we make around small tweaks, which we think will be quite powerful. And also, obviously, trying to drive more research and potential follow-up studies. So I think I've been talking for a bit of a while. I'll just stop sharing, and if you have any questions, be happy to answer them. Thank you.
Thanks, Joe. That was really interesting, and thanks for sharing that with us today. We haven't got any questions on the Menti. I don't know whether anybody in the room has got any questions for Joe. My only, I suppose my sort of observation was this is quite a sort of a specialist area. Well, obviously it's very focused on epilepsy. I just wondered if you felt that some of the findings were transferable to other sort of discrete kind of conditions as well, i.e. the relationship between having access to a specialist nurse and sort of subsequent better care plans and so on.
Yeah, definitely. I think for sure, sort of autism, learning development, anything around special educational needs. I've always wanted to do a project on sort of more rare diseases because I do think there'll be a link there between epilepsy and some of these more kind of unknown conditions. I mean, for sure, the better care planning you have just for epilepsy will have benefits across all these other comorbidities. I showed the link. There is a strong link between epilepsy and mental health. Understandably, if you're having seizures very often, you're going to be anxious about them, particularly as a child. So I think care planning will help your epilepsy symptoms, but it can also help your mental health symptoms.
Did it, and you probably covered it in the presentation, but so I think we all know somebody who has epilepsy or somebody who knows somebody who has epilepsy, and it seems to appear at different times for different people. I think you probably covered it earlier in the presentation. Is there a sort of a typical age where it or an age band where it can present in sort of children?
I don't really know is the answer. Yeah, I think I suspect, and I don't know for sure, but if in the first year of care, I imagine is very important, particularly for the more severe epilepsy. I imagine if you have structural brain abnormalities which lead to epilepsy, then they're going to present at birth. But I don't know that for sure. I'm not a specialist, but my personal experience.
Ewan.
Yeah, please. Yeah.
Hello, thank you so much. That was really, really great. I mean, like some of the analytical techniques like I haven't seen before, so I was wondering if your code is available for us to not steal, but learn from.
Yeah, no, it can be. I take out all the data and we'll put it on a public GitHub, and all the methods are, open source. So yeah, it can be, definitely.
Amazing, thank you.
Yeah, some of them are some of them you will have definitely done. Some are a bit more niche, probably. So particularly around causation, that's always quite, you don't always do causation on analytics. So you can definitely have a look. We also, some of the techniques, we've done a little bit of training in the Midlands Decision Support Network on. So there may be a video somewhere around using them.
Yeah, maybe stroke definitely is. But I was just on that. I think it might be useful for a huddle actually, Joe, to maybe sort of like pick on one of those sort of techniques and give people a bit of a fuller introduction to the particular techniques, because people don't necessarily, well, most people won't use the techniques and won't have the confidence to try them. So sort of like a mini taster session, I suppose, or just sort of a mini training session on one or two of these things. I think that might appeal to people. When I invite people to say what they would like to see more of in these sessions, mini training sessions, just to get people a bit more exposure to some techniques that wouldn't normally use. I think that they're usually very popular. So this is you saying yes, that's literally you committing to coming back. You realise that, don't you? I mean, this is fine. It's fine. It's being recorded. It's all good, and the boss is in the room, so this is all going very well for me.
Yeah, sure.
Yeah, no, that'd be really good.
There are definitely some techniques that can be very helpful for these kind of projects, particularly because sometimes you get to a stage in a project and you're so lost in the data and you've got so many variables that there are just some techniques which can kind of really clarify what to do. So factor analysis, for instance, it's all about just reducing the complexity of your data down. So it's very useful. But I definitely got to,
Yeah, it does feel like it. So I mean, just sort of exploding that a bit in a session, just to say no, you were overwhelmed. I didn't know what to do. I said to Andy, what shall I do? Actually, I think I haven't set up the questions very well. Somebody put a question in on the band. I just something flashed up and I realized I must have set the questions up wrong. I think someone's asked about the band, but I think it would be even if it was just to to save you doing loads of extra work, if you were to explode what you did during this process. You had all this data, and everybody gets to that stage in a project, don't they? When you got data maybe from different sources, or just it's no clear route to sort of the best way to analyze it, what's the most important things, and so on. It does feel like it's a useful technique for people to be exposed to a bit more, and people don't, generally speaking, in their work look for brand new techniques, especially when they're in the middle of everything. That isn't the time to sort of think, oh, what else can I do, kind of thing. But if you start out thinking this data this analysis feels like it's going in that direction, and that might be a useful tool. Great, that's really useful. So have I set the questions up wrong? So people are, I suspect, or someone's just put a comment, right? And who was it? Are they actually going to be brave enough to say who they were and what the comment was? Otherwise I'll just have to make it up, and that's just dangerous. I think it mentioned the band. Yes, okay, well, thank you ever so much, Joe, for talking to us about the work. Really important work. Feels like the recommendations are something, if taken on, will have an impact. That's what we're all about, isn't it? So thank you. And before I sort of move on to one or two other things, I'll just say look forward to seeing you and the guys and the girls at Hacker in July. And just for everybody else who's wondering if there are any tickets left, there's a few but they are dwindling, and I think I'm not supposed to be promoting it too much in the Midlands, because I've done too much of a good job on that so far, because we need a nice geographical coverage. But you're my friends, and so I cannot help but to encourage you to come, and it'd be great to see as many of you as possible there as well. So thank you, Joe. So I'm gonna move us on a little bit, and so we can sort of finish a little bit earlier today. So I think I'm just going to share my screen again. Let's see what I can do here. Yeah, so in the next couple of huddles, we've got the next one is about demand forecasting for executives and professionals. So this is kind of a follow-on from one of last year's Hacker e-labs, and it was very, very popular, and it should be very accessible to analysts and beyond. So this is to analysts and leaders as well. The way it will be framed is making demand forecasting accessible to everybody. So I think it'll be a really good session next time as well. And then we've got strategy units, Paul Seamer, estimating the impact of population and morbidity changes on healthcare utilisation. Another session which I'm very much looking forward to. I keep putting on here that we're going to have a session all about intelligence functions. I still think we should have a session all about intelligence functions, and if nobody comes forward, I'll make that one up, because I think it's very useful for people to know where we're at with them and how it impacts on you or not. And then finally, yeah, I might have mentioned it before, Hacker 2024, we really are sort of coming to the last sort of 50 to 100 tickets available for that in-person session in Telford on the 23rd and 24th of July. You're all very welcome. And we've got the e-labs out now as well. So 3 of the e-labs are on the programme, and you can sign up for those right now. So I won't go into the detail of what those are, and there are more coming as well. So that's also fantastic. And we have a new training and development regime which is coming very soon, and I'm looking forward to trying to hold back. Not very good at keeping secrets, but I'm looking forward to telling you more about that soon. So I will stop sharing, and I will finish us a bit early today. So thank you again, Joe. Thank you everybody else for coming, and I'll see you all in a couple of weeks. So bye.